An implant protocol company called 3 on 6 claims that 90% of all on 4 patients are candidates for FP1 teeth-only prostheses. But our prosthodontists are calling this the biggest lie in implant dentistry. The real number is closer to 10%, and here's why that matters for your treatment. Today, our prosthodontists at North Texas Dental Surgery are exposing the truth about FP1 versus FP3 prostheses. You'll discover why FP1 requires the stars to perfectly align with bone position, implant placement, and smile line. Also, we discuss why most patients who need all-on-4 are actually periodontal patients who've lost bone and gums, making them automatic FP3 candidates. And we will discuss the shocking reality that even successful FP1 cases can catastrophically fail after 5 to 10 years. And stay tuned for real case studies, including a patient whose FP1 looked perfect for a decade before complete failure, why FP1 often requires extensive bone grafting that costs more time and money, and the uncomfortable truth that there are no absolutes in healthcare. Anyone promising 100% success rates should be avoided. This could save you from choosing the wrong prosthetic type based on misleading marketing. Let's talk about FP1 versus FP3. Okay, so the average person out there is going to know it due to marketing 3 on 6, which FP1 doesn't have to be 3 on 6, but FP1 versus FP3, which is FP3 would be like an all-on-4 type of solution. So what are your thoughts about FP1 versus FP3? Because again, I have my thoughts.
Yeah, I think FP1 is a great treatment modality to start things off. I think if executed well, it's it's what, frankly, I would get in my mouth. But for that to happen, I really have to wish for stars to align. It's almost like there's so much precision involved in it that any deviation from the plan, and you're at a point where you're really questioning that why would I do an FP1 at this point? You have very little room to get, your implant position has to be perfect. Your prosthesis has to be perfect, and we know from what, our discussion that it takes a while to finalize the prosthetic position of your teeth. And if you're finalizing the position of your implants and you don't have a lot of room to deviate the prosthesis, then really you don't have enough room to change things. It is probably less aggressive in the short term, but if you start to lose bone around those implants in the future and you start to show that junction soon, because within FP1, your style of placement is different, your contouring is different. So if done well, it's great. But if the bone starts to recede, if you have very long teeth, so you're not really aesthetically kind of having a good outcome. Long term, functionally, you're not having a good outcome. So why are you employing it? And it goes down to, like we were discussing, that when we look at the patient, we look at what's missing. If the only thing that they're missing is teeth and they have a low smile line, great. I think that's a great patient for FP1. But if they're missing a lot of volume, then there's no way you can put an FP1 in that patient. I mean, a lot of people would, but I think that a blanket statement that all patients are good candidates for FP1 or all patients are good candidates for FP3, I think that's wrong. It's like, I think this is a universal truth for any treatment. Anyone who says that XYZ treatment is good for all patients, there's no way around it. Because there are no absolutes in healthcare. Like, no one can say this is 100% success. There is 0% success. If anyone tells me that what I'm doing is 100% successful, I'm never going to that person.
Along those lines, I wanted to also say that back about 6 months ago, some representative from 3 on 6 left a comment on one of our YouTube videos and said that, hey, maybe we need to have a conversation because, quite frankly, 90% of all fixed full arch cases out there are actually FP1 3 on 6 candidates. And I was like, that couldn't be further from the truth. I mean, what are your thoughts about that?
I personally think it's the other way around. I think it's probably somewhere around like 10 to 15% at max. And if we're talking a population of low smile line, people who've lost only the teeth portion of the dentition and just the maxilla. So if you're doing just maxilla, if you do, upper and lower arches only, that's 50% of cases that qualify for FP1. Because I would never do an FP1 on the bottom. I would definitely only try to focus on the top. And out of those upper arches, I would say maybe like 5 or 10% of those upper arches might be good candidates for FP1. Because like I said, we have to take into account the smile window, the incisor position, and a lot of other factors.
And not saying that it can't be done, but what we're also saying is we're insinuating that we could do it, but there may be some aesthetic compromises, right? So if I'm now trying to execute a surgery, I'm trying to preserve as much interproximal bone, facial bone. Everybody's got a different biotype, meaning different thickness of bone and gum. And even if I'm being as careful as possible, then we may lose some interproximal bone or something, which then will affect their papilla, which then that patient will have to resort to very squarish teeth. And or if the bone is not all in perfect positions also, we are now affecting your gingival margins, right? So now we're going to have asymmetry. So if a patient has a high smile line and they don't know about this, then they could be very, very displeased, and you might have a very upset patient in the end.
Yeah. I think like going back to like expectations, short term it's a great option, but I mean, if you look at the grand scheme of things, I think creating an aesthetic outcome with normal sized teeth for the patient's face, it's hard to, because what I've seen a lot of FP1s done is that when the teeth are extremely long, so almost it's like an FP2.
They are FP2s,
Yeah.
and they're calling them FP1s.
Right.
Yeah.
Because a lot of we have to understand that FP2 is essentially white with a little bit of yellow to show the root form, right? If you merge those two, it just becomes an overextended FP1. But more than the terminology, it's just about having an aesthetic outcome that's long-term functional for the patient. And I think that I don't feel comfortable personally prescribing FP1 to all patients, or even like 90% of my patients. I would say like for that to happen, I really have to. I mean, if done well, I would do it the traditional way, where I would stage the case, where I would know exactly where my teeth will be. I think personally that would be the best way to do at FP1, where your teeth position or prospective teeth position is already finalized, and now you're just going in, filling where the implants need to be, and now you know exactly where your hole is going to come out of, the access holes for the implants, and you kind of almost like starting with the end in mind.
Right. So you're not going to do everything in one day.
Yeah, absolutely.
But a lot of patients might not want to hear that, right? Here in America, we want quick fixes. I want my permanent teeth in one day, right? What are your thoughts about this?
I mean, I love FP1. I think it's a really good solution, but I think it's very simple to understand that an FP1 means that we're only replacing the white part, missing teeth,
Right.
which means like all our periodontal patients are not candidates for FP1,
Right.
because they already like lost pink, which means like gums or bone. So the candidates for FP1 are only the ones that still have their teeth and the teeth have to be extracted. Let's say like caries patients.
Tooth wear or caries, right?
So those are the only candidates, considering that the teeth are in the right position. Because if the teeth are already in the wrong position, then we have to go through an FP3. Obviously, there's many FP1s out there that there are FP2s. So FP2, in my opinion, we should do an FP3 instead of an FP2. Mm-hmm. And then the problem comes, when we find the patient that I think it's more than a 10%, to be honest. I cannot give you a number, but I think that it's more than 10, I don't know, but it's more than 10%. There's a lot of patients candidates for FP1.
But it's definitely not 90%.
It's just because then you tell me that only like 90% of the patients who get a full mouth implant rehabilitation, they're non-periodontal patients. And that's not true. Most of the patients that need like full mouth implants are periodontal patients because they've lost their teeth, you know what I mean? So let's say that we have like a lot of patients that need an FP1, that they're candidates. Then the thing comes, is there enough bone? Because for an FP1, we cannot resect the bone. Because if you're resecting the bone, then you cannot cut the bone. You have to go for an FP3. So in my opinion, FP1s are doable in a lot of patients, but most of the patients that need FP1, they're going to need severe bone grafting because there's not enough bone. So then the thing comes.
Guided bone regeneration, more cost?
More cost, more financial cost, more biological cost. And what happens with grafted bone or soft tissue bone or soft tissue grafting after the years? It shrinks. So for me, the main problem is that even if you find the candidate, there's a lot of like FP1 candidates. So if you want an FP1, you're going to need to know that it's going to take longer because we're going to need to graft your bone. Then we're going to need to do more sets of temporaries because we have to control the tissue more. And we're in America, time is money. So the financial cost of that prosthesis is going to be higher. So I think it's doable, but not on the 90% of the patients. Patient that wants an FP1 and it's a candidate, they need to understand that it takes more time, more money, and probably a lot of grafting, hard tissue and soft tissue. And they need to understand that it's more predictable to cut bone than to grow bone. I love FP1, but I think it's just like being realistic with patients. And saying that 90% of the patients are FP1 candidates, that's not true. FP2 candidates, yeah, that's okay.
Right.
Yeah, I think I would say like 80-90% of patients would be like FP2 candidates if that's what we're talking about.
Yeah.
But then FP1 kind of draws a line where you're just removing the tooth part. So I think that's where the difference comes. Because FP2, FP3 is almost like in, you know,
just either pink or yellow, you know?
Yeah, pink or yellow, yeah. I've seen a lot of European lectures where, you know, when they're doing an FP1, they're almost doing a prophylactic crown lengthening, that they're actually crown lengthening the teeth before they extract the teeth to get the bone where they need it to be. And then they stage the case. That's, I think, a great way to do it because you know how the bone is going to remodel, where you're going to where your bone is going to be, and what your aesthetics are going to look like. And then you can plan where the implants are going to be. I think just going straight for you know, the procedure like we do in America, like you said, time is money. I think it'll be difficult to get an FP1 and do it all in same day for 100% of the patients. I think that's an outreach.
Yeah, so me knowing what I know, my surgical perspective is having extracted an insane amount of teeth, doing full arch extractions. We know that when you're taking all of the teeth out at one time, that there is more of a chance that you lose a facial plate or interproximal bone, right? Which is going to be essential to do a proper FP1, right? And so I don't have the highest smile line, but I don't have the lowest smile line either. So what would I do in that situation? We had conversations about this earlier. I would do things over time, right? But again, that's not the answer that a lot of patients want to hear. They want to get everything done at one time. And then this guy says that he could do it all at one time, then you must not be good enough, right? But the reality is like, if we really want what's best for that patient, you want full transparency, then that's probably what they should consider. Do I love FP1? Exactly. Like I mentioned earlier, like, yeah, I'm a big fan also. But again, I feel that there's way less candidates for it. And one thing that I want to give my surgical perspective of is when I'm doing an implant for implant bridges FP1, whatever I'm doing, a single anterior implant, my goal is to make sure that obviously I need to place this implant in a prosthetically favorable position. Otherwise, no matter what you do, you're not going to be able to do a good job, right? So I need to get that implant in a good position. The problem with that is, how do I also do that and make sure that I have adequate buccal bone thickness and soft tissue, because that's going to be one of your biggest predeterminers of long-term success for that dental implant, both functionally and aesthetically. And that really is now going to be compromising me if you tell me, hey, I don't want you to tell me to place that implant where the bone is. I need you to place it where it's going to be ideal for me to put this screw access hole through the cingulum of the tooth, right? And so now we're going to be at odds, right? So now suddenly we're losing half of our patients, right? But again, FP1 could be a great solution, but unfortunately, and I think this is why this needs to be an entirely separate video, which is probably going to be an hour and a half. Things get very, very, very deep in the weeds, not only from a surgical perspective, but very deep in the weeds from the prosthetic perspective. And then we have to marry both of them. So we are going to be jumping through more and more hoops to make sure that, as you said earlier, that the stars are going to align for that patient to be a true FP1 patient who's going to have long-term success. No matter, like, as we established earlier, that patient, we could look at that x-rays who had that failed all-on-4 that was 5-6 years old. Anybody could look at that and be like, oh my God, this patient has improper sizing of implants, excessive cantilevers. This is going to be a disaster one day. They could have seen that on day one, but that still lasted 5 years. Now, is that success? You asked that patient a year ago, that was success, right? Now you ask her now, she's like, no, that's an utter failure, and I had to spend a lot of money to get this situation. I spent that money in the first place, and I also had to spend money to get it fixed, right? And so our goal with all our videos is to make sure that that patient is going to have long-term success. Again, we've seen these cases. Dr. Khan, I mean, he's a fantastic surgeon lecturer, prosthodontist, right? And he's out in California, years of experience. And he, 6 months ago when we were in San Diego, showed this case where he had this, he openly admitted that he did an immediate implant on this case. It was like tooth number 9. This case looked fantastic for 9 or 10 years. You never would have known, this patient lived in India. You would never would have known that this patient was going to have issues. And anyone could look at that without looking at a CBCT would say that that implant is a success. She came back from India, she had issues, she lost the implant. They tried doing guided bone regeneration, trying to do all these things, try to like even fix that site, but there was so much devastation in the area, they couldn't place another implant.
I think it's the main thing to understand for everyone is that predicting remodeling is incredibly difficult.
Right.
Even if you graft with the best grafting material in the world, we don't know how much and where the body will take and keep it for years, like long term. So I think that's where you kind of said, prescribing the treatment to the patient appropriately is the most important thing. Like we had the other patient where the smile line was very high, but the FP1 was done. And we saw,
Yep.
And the abutments were showing, and she was very unhappy. She didn't want to smile. She had a beautiful smile, and it wasn't even a very high smile line. I think she had a moderately high smile line,
Right.
And even then, so I think prescribing one treatment for every patient is I don't think that should be done. In her case, they didn't want to remove a lot of bone. They were hesitant to remove bone, and in that attempt, they gave the patient something that essentially had to be removed within a couple of years.